Oh, welcome. So, one second. So, this is the Heidelberg SLO image, and we oftentimes concentrate on the actual OCT to the right. But the SLO image also gives you some information. Here it is very obvious that this patient has geographic atrophy, so it can help you with your diagnosis to the right side. And this is similar to the last slide, that if you follow along the outer retina, it does stop, and then you know the retina, inner retina is diving into the gap, and then it starts again. So this is geographic atrophy. We have choroidal hypertransmission because the RPE is missing, and then we have loss of the retina outer layers. And of course, we do not inject this. Okay, so let's say you have this choroidal atrophy near the fovea of the left eye, and then you have hemorrhage adjacent to that. What do you do about that? Do you treat or do you not treat? Emmanuel, do you want?
Well, the presence of subretinal blood clearly shows the sign of some activity. So I would, if I had the opportunity here to perform a fluorescein angiography, I would expect to find the CNV adjacent to the area of geographic atrophy. So maybe this is something that needs to be treated.
Okay, yes, I agree. Even though the patient's hemorrhage is adjacent, I would treat because of the hemorrhage. Okay, so Emmanuel, do you want to select a resident who can tell me what this diagnosis is? And you can decide the diagnosis in just this one slide.
Sure. Ποιος είναι? Κορομπίλια, Αγλαία, Λίνα, θα μας πεις? Σταυρούλα, Ντάουλα, θα μας πεις?
Hello. There is intraretinal fluid and subretinal fluid. Maybe I see there vitreomacular traction, and seems like schisis or.
Okay, schisis would be on the differential. What else? Just to let you know, this is more like vitreomacular adhesion. The definition of traction involves an acute angle of the vitreous on the retina. This is more of like a softer interaction. So based on this one OCT alone, you said schisis, which could be on the differential. Anything else on the differential? What about a vascular etiology?
Yes. Maybe a CRVO, edema from a CRVO.
And one more to put on the differential.
And
it would be very severe, of course, but I would put diabetic macular edema on this list as well. So when you look at this part, the nerve fiber layer, can you make any comments about it? Does it look normal to you, or does it look something different?
It's thickened, I think, this layer.
So it's actually more hyper-reflective. It's brighter. you see that it's brighter?
Yes.
So if it's brighter, it means it is ischemic. So which of those three diagnoses would lead to ischemia of the inner retina?
Of the, it's something vascular, retinal artery occlusion.
So actually just the vein occlusion alone, so those three were great, just the vein occlusion alone can have an ischemic portion of the inner retina. So on this OCT, we have central retinal vein occlusion, as you said, with inner retinal fluid, subretinal fluid, and the clue that it is not diabetic macular edema is this inner ischemia. So this is another photo of vein occlusion. Again, large cysts in the inner outer retinal fluid as well. Again, central retinal vein occlusion. This is a patient I saw just a few weeks ago. Very large subretinal fluid, very much inner retina, and so much, fluid that the signal doesn't even show through so much. And again, the pictures of central retinal vein occlusions can be very dramatic. It's a very puzzling disease in the sense that you have one insult to your eye and you can have very, very large recurrences of fluid. So you can have a very perfect looking retina after treatment and the fluid comes back. Very classic picture of multiple hemorrhages in the periphery. This is what you would see on exam. You may or may not have optic nerve congestion. But you oftentimes have hemorrhages that persist. Even though your macula may look great with treatment, the hemorrhages oftentimes persist. And a picture of a more classic version of the very tortuous vessels, the dot blot hemorrhages and the flame hemorrhages that are in the nerve fiber layer. And as you know, the reason why the flame hemorrhages are straight out or they look like flames is because they sit in the nerve fiber layer, so they are oriented like this. Dot blot hemorrhages are oriented vertically because they are in between the Mueller cells. So we have central retinal vein occlusion, we have large intraretinal fluid, subretinal fluid, and the RPE, remember I told you if you follow the RPE, you will know what the part of the diagnosis is. And as I mentioned, you have dramatic recurrences. So we do inject these patients, we typically inject with anti-VEGF first line. I know in Europe, steroids and Ozurdex are more popular than in Canada, and definitely more popular than the United States. The United States in general is very anti-steroid. In Canada, it's a little bit of both. Okay, Manuel, do you want to pick someone for this diagnosis?
Σταμάτη, θέλεις να μας πεις?
Yes, in this case, we can see an OCT image with intraretinal cysts conform with edema and hyperreflective accumulations that could be exudates, for example.
I agree. So, so the diagnosis is, what would you say? Sorry if I missed it.
It may be of a diabetic etiology because we have a combination of intraretinal cystic edema and the exudates. So. Perfect.
Are you a resident or a fellow?
No, I'm a resident.
Oh, a senior resident?
At the last semester, let's say.
Excellent, excellent. Okay, so you're completely right. Hard exudates, intraretinal fluid, more so in the outer retina, and you could perhaps consider these hyperreflective foci as well. And now that you know the term hyperreflective foci, you will see it in many different diagnoses when you look on your OCT. And there's a whole concept of biomarkers for imaging, especially in OCT, that provides you prognostic information about how the patient will do. And this is important, you know, if you read articles by Vasada, he discusses this a lot for macular degeneration. And we want to be able to tell the patient how many, what their prognosis is, how many injections they're going to need. And the most important question that they ask you is typically, doctor, do I really need this treatment? And it's nice to be able to share with them some evidence as to why. So more photos of diabetic macular edema. We have large intraretinal cysts, and we have cysts on the side. And sometimes you can inject a patient every single month for a year or maybe 2 years, and they may still have a little cyst in the center. And sometimes it's okay to have a cyst. You don't have to chase all of the fluid in an OCT. You don't have to go after every single little bit of fluid. And in fact, the protocol V results, which compared the DRCR protocol V, which compared laser to Eylea to observation for DME 2025 or better, showed that all three are pretty equivalent. So it's okay to wait, and it's okay to not treat patients if their vision is good. In general, we have gotten into the habit of treating patients like this with fluid. And what I do is, if they have a cyst that does not improve, I basically ignore that cyst and I tell the patient this is a chronic cyst. This is not going to change. But what we do is we look at the ancillary fluid. So we look at the fluid to the side of the fovea so that we can look at that as responsive or unresponsive. So in my note, I will write patient responsive to Eylea at 4 weeks on OCT cut number 4, let's say, if they're doing a 5-line raster. And the reason why I do that is that you can look at the same picture again the following month and then decide whether they're responsive or not. So let's say you bring the patient back at a month after 3 injections, and they still look like this. What would be your next step? Emmanuel, do you want to ask somebody?
Πέτρος Ντόβας. Για πες μας.
So if the edema persists, I would order a fluorodiography to investigate if there is some peripheral ischemia that makes the edema persist, maybe.
Okay, great. And then do you like to do sector PRP laser to those ischemic areas?
If there is this indication from the fluorodiography, I would initiate PRP.
Okay. Well, there is a version of PRP that is called target PRP, not a typical PRP. So the indications for PRP, as you know, are you need to have a high-risk criteria. So you need to have neovascularization of the disc or neovascularization elsewhere with vitreous hemorrhage. And there is a different version of target PRP where you look for ischemic areas and then just laser those areas. And that is not standard of care, but it's something I consider sometimes. So let's say the peripheral, you do an optos angiogram and there is no ischemia in the periphery. What would you do next after these 3 injections? And the patient still has not had more than 20% improvement of center macular thickness.
Maybe I would advise the patient to regulate his blood pressure and regulate his blood sugar in order to take care of the systemic causes that may lead to the edema to persist.
Yes, and what else would you do? Let's say patient's A1C is 6.5. What would you do differently in terms of treatment of the patient? Or not differently. What would you do next step? Patient has had 3 injections, 3 monthly injections. You have to tell them what's happening next. Do you bring them back for another injection at another month? Do you switch drugs?
So close monitoring is one solution. Another would be to consider another kind of drug like Ozurdex, maybe, for persisting diabetic edemas.
Great. So what I do is I bring the patient back at 1 or 2 weeks. I repeat their OCT at 1 or 2 weeks, and then I can tell, is it really unresponsive, or is it just responsive and then the fluid comes back at 4 weeks? And that way you have more evidence to decide whether it is worthwhile to continue on their anti-VEGF, or is it worthwhile to switch to Ozurdex or any kind of steroid. Of course, steroid has higher risk with 30% increase in intraocular pressure and risk of phakic patients turning into cataracts. Many diabetic patients are phakic, so it is a risk. So I want to know whether the anti-VEGF is just not working at all, or is it just suboptimal? So if the OCT is better at 1 or 2 weeks, then I'll continue with monthly. After 6 months, what I do is I may ask them, if they're on Eylea, I may ask them to come back at 2 weeks for an Avastin, and we'll inject every 2 weeks and see if that's better for the patient. And then if it doesn't work, then I would switch to a steroid, depending on how much fluid there is, of course. Emmanuel, do you have anything to add to that?
We have here with us in the panel a few vitreoretinal surgeons. So we have Alexander Hadronis, we have Vangelos Manousakis, and Spiros Kanelopoulos. Any of the three to comment on this? Alexander, how is your approach for the persisting diabetic macular edema? And then Vangelis and Spiros can make a comment. Thank you.
Hello. Well,
speak loudly. We're not sleeping here. Alexander, speak, man.
I'm wide awake. I'm wide awake.
That's good. Okay, go for it.
So basically, in terms of persistent diabetic macular edema, I have moved more towards, doing more anti-VEGF injections more aggressively, and switch a little bit later on, perhaps after the 6th injection. That's an overall, but after the first 3 injections, if I don't get the real response, I'll start, discussing with the patient and letting him know that, we might change gears and we might need to add something else. Now, I have used every 2 weeks, I have to admit, in macular degeneration, but I haven't used every 2 weeks in diabetic macular edema. In my view, diabetic macular edema is something more chronic and things move slower, I would suggest. And I think that the overall effect of anti-VEGF in diabetic macular edema in general in diabetic retinopathy is something that you see a lot down the road. And we also have to keep in mind that even if we do switch to a steroid treatment, we kind of miss the disease modification effect that anti-VEGFs might have in the long run. So this is also something that we need to keep in mind, that we need to get into the mindset that we treat diabetic retinopathy in general, not necessarily just treating cyst or treating intraretinal fluid.
Right. Yes, DEEPA, yes.
No, I was just going to say that that's a great point. The Protocol I 4-year and 5-year data shows that you only actually need 1 or 2, actually 0 or 1 injections in year 4 or 5 of treatment of diabetic macular edema. So what does that tell us? That tells us that the work that you do at the beginning of this disease is very useful for the long-term management of this disease. So yes, you do have reversal of 2 categories of diabetic retinopathy severity score. So 2 steps, which is very important, and so important, in fact, that any drug right now, according to the FDA, only needs to reverse diabetic retinopathy by 2 steps in order to be approved in the United States. So that alone is sufficient as a useful outcome. I agree, it is a slower disease. We end up oftentimes just injecting every month. And it can take a year or so even to make any changes. But I had a patient who is a neurosurgeon who was very well controlled with an A1C of about 7. He's a very skinny guy, obviously very motivated. And I treated him with all kinds of things for about 2 years and brought him back at 1 or 2 weeks. And it wasn't much better at 1 or 2 weeks. Did, of course, Ozurdex, finally gave him Iluvien. And along the process, there's a couple of things that we discovered. First of all, his A1C was good and his sugars were good. But when he got a glucose monitoring, you know, they have a little, I forgot the word of it, continuous glucose monitor.
Yeah.
And it wasn't an insulin pump, but just the monitor to show what his sugar is every 5 minutes or so. And he learned that the way insulin works on his body is different than what he would expect. So he learned that a regular insulin, so there's long-term insulin, of course, and regular insulin. And he learned that the regular insulin, which is supposed to work in 20 minutes, for him took an hour or more than an hour. So he would time his insulin with his meals, but it just wasn't working. So there's a lot of diabetic patients are much more complicated to treat than macular degeneration patients. There's a lot of questions you can ask. There's a lot of things you can do to help these patients. And of course, treatment is more complicated. We talked about switching drugs. We didn't even talk about grid laser or focal laser. And of course, those are options as well. Emmanuel, is that how you typically treat the patients?
Yeah, absolutely. So, Spiros, any comments?
Hello. Well, I agree that diabetic patients are chronic patients and have multiple problems that can affect the course of their disease. But speaking for the treatment in the diabetic edema, we must have in mind that our purpose is to rescue or to save or to make the vision of the patient better. So we must first see what is our goal in this attempt. If we have a macula that is ischemic, or if we have a lot of exudates under the macula that cannot retreat with our therapy, maybe there is no need to have a patient under injection all the time. So we must see first what is our goal and then decide what is our treatment.
I completely agree. That's very good advice. And actually, we have Emmanuel, are all of these attendees invited to Retina Connect? Do they know what it is?
Sure.
So this coming Tuesday on this Retina Connect webinar that we do, it's now at 5 p.m. on Tuesdays.
That's the problem, DEEPA. 5 p.m. Is meaning midnight or even later. So everybody is sleeping. Yeah.
And
so it used to be 4 p.m. That was 11 p.m. So now it's 5 p.m. So it's gonna be midnight. Midnight, you know, people in Greece, especially vitreoretinal surgeons and surgeons, generally they go to bed because next morning we need to wake up at 6 o'clock.
But retina people are very passionate about a retina, you know.
Yeah. So, okay. So I will promise you, I will distribute the link, and whoever wishes can attend Retina Connect. It's an awesome teaching tool and educational, very educational.
Yeah. What I was going to say is all of the sessions are recorded, so you can always watch them later. The session this coming Tuesday is what happens when you stop anti-VEGF.
Right.
So Rishi Singh from Cleveland Clinic has studies on AMD and DME to share, and this is obviously very relevant to right now because we've had to stop injections on many patients, and we need to know the risks of doing that, especially if COVID has a recurrence in the fall, in the winter, maybe worse recurrence, maybe when the borders open up, who knows what's going to happen. So it's good information to have moving forward.
So just because we have residents and fellows as well, I want a take-home message for the difficult cases of diabetic macular edema, not responding to, let's say, 6 intravitreal injections. What is the message for them to take home of how to proceed after the 6th injection? DEEPA?
If they show a response at 1 or 2 weeks.
And let's say that this is a central DME that does not require a focal laser, right?
Yes. Of course, with angiogram, if we see that there are safe microaneurysms to laser, then we laser, or you could consider grid laser, more extrafoveal. However, for the central macular edema, as Emmanuel said, I do bring them back at 1 or 2 weeks. If it is better, then I know the anti-VEGF is working. And I continue with the anti-VEGF. If it is not working, then I would switch. If it's not a ischemic peripheral, I would switch to steroid. My steroid of choice is Ozurdex. Of course, if the patient has insurance to pay for it, otherwise it's $2,000 and nobody pays out of pocket for that. And I have been doing some Iluvien, which is supposed to work 2 to 3 years. I would only consider that probably about after 1 year or 2 of treatment. When I do switch to steroid, it is actually not a switch. I do combination. So I give them the steroid and then continue with their anti-VEGF, and hopefully both together work together. As the other retina specialist mentioned, you don't want to lose the benefit of the anti-VEGF because reversing the diabetic retinopathy score is very important. Lee Jampol, we've had Lee Jampol as speakers a couple of times in the last 2 weeks, and he agrees that the current diabetic retinopathy severity score with all the different levels is very outdated. And they are working towards or hoping to work towards a more relevant and useful diabetic retinopathy severity score.
Thank you.
So just going through the images of diabetes, I just want to show you more examples. You can have hard exudate nearing the fovea. If I see hard exudate nearing the fovea, I am more likely to treat early. I don't want this fovea to, this exudate to grow. I don't want the exudate to go into the fovea. Exudate in the fovea can cause a scotoma and can end up being very hard to treat long term. And just more examples of diabetic macular edema. You have hyperreflective foci in the inner retina and the outer retina. You can have large cysts that are with clear fluid. You can have more opaque cysts with chronic fluid. You can have more atrophic areas of the outer retina. Does someone want to see, and here you have the opaque fluid in the central cyst, and you can tell sometimes these cysts are just not going to change. They're chronic, they're fixed, they're structural, and they're just not going to get better. Does someone want to tell me what drill is? Have you heard that term, drill? So drill is a disorganized.
I'm Spiros Kanelopoulos. Drill is the total dissociation of the retinal layers, like we see in the last picture there, down to the right.
So we have so drill is the disorganization of the retinal layers, and that happens when you don't have what you look for is when you lose the definition of the lines of the retina. So so for here, you know, you could potentially say that you don't see the layer. You may see it here, but here you don't really see the layers of the retina. So for example, here you can see the layers, but you don't see it there. And you don't see it everywhere here. So it's a finding in diabetic macular edema that shows that eye may not have the maximal potential that you need. In terms of take-home messages, as Emmanuel mentioned before, if we decide that the maximum vision for a patient is, let's say, 2200 at when their fluid is gone, then we know that if the vision is still 2200 when there's fluid like this or fluid like this, that you don't have to be so aggressive in treating the patient, because we know that that is their maximum vision and it's not going to change. So maybe we don't have to bring them back every 2 weeks or even every 4 weeks if it's decreasing their quality of life. Diabetic patients unfortunately have many appointments during the year. There's a number, something like 33 days lost of work for every patient, just for doctor's appointments alone. And these are working people, so we don't want them to lose their job and we don't want them to lose their income. So I think it's important to support them socially in addition to medically. A more classic picture with lots and lots of exudate, dot blot hemorrhages, flame hemorrhages, and here the exudate is going into the fovea. So I would be very quick to do laser in this area and perhaps in this area as well, in addition to anti-VEGF to manage this exudate and fluid. So diabetic macular edema, intraretinal fluid, subretinal fluid, as we discuss, intact RPE and the exudate, and the color photos are obviously very helpful in terms of diagnosis. So we inject these patients. This is the last diagnosis in this part of the lecture, and I know we're hitting the end of the time. Emmanuel, do we have time to go on with the next part of the lecture, or do you want to end after this?
It's unlimited for you, DEEPA. Go ahead.
It's also people's dinner time, right?
When things come to knowledge, there is no dinner. Go ahead.
Okay, well, you just let me know when to wrap up. I can, of course, talk about retina forever, so I can get carried away as well. Okay, so this is, again, a spot the diagnosis, something that you can tell what the diagnosis is based on one OCT. Emmanuel, do you want to select a resident to tell me what the diagnosis is?
Sure. Elena Konstantinidou.
Yes, I would say that there is an OCT where we see a photoreceptor, a focal photoreceptor loss, and under the fovea, and intraretinal cyst. Maybe it could be a MACTEL.
Wonderful. So this is absolutely right. MACTEL is something that you learn. What year resident are you?
4th.
Great.
She's just preparing for the final exam. She's going to be an ophthalmologist in June. So
congratulations. So this is a very nice diagnosis to be able to identify, and sometimes you just with experience you learn these characteristics. So the way I explain it to the residents is, it looks like like a moth came and ate part of your retina. It looks like something came and chewed part of it. You're missing these gaps of retina that don't even make sense. It doesn't look like typical fluid. It looks like it's atrophic, and it can come in many different patterns. So you can have more atrophic spots. The outer retina can be affected. There's sometimes gaps in your outer retina. Sometimes it gets scarred up over time. So these could all be examples of MACTEL type 2. MACTEL type 2, the other terms for it are idiopathic juxtafoveal telangiectasia. So you can have atrophic cysts of the inner retina, intraretinal spaces that don't distort the foveal contour and then the gaps in the outer retina. This can be associated with CNV. So if they are associated with CNV, then you would inject them, obviously. But when they are just presenting like this, you can just follow them. You do not need to inject. Okay, so any questions about those OCTs and the diagnosis that we reviewed so far?
Hi.
Hi.
Can I ask you a question about McTell? You said we generally know that you do not inject unless you see a neovascularization. Although yes. I have heard that if you see a type 2 McTell that progresses and does not produce any neovascularization, you can still inject one dose of anti-VEGF in hopes that may inhibit the progression, not heal it, but that it may inhibit it. I have heard that. I can't find it in any published paper, but it is something that I would like to know your opinion about.
Yes, actually, I had a discussion with Mark Gillies. I don't know if you know who he is. He's in Australia, and he's the principal investigator for a very large MACTEL study. So we will be knowing more information about that, over the next little while. But I asked him what his opinion is of that, and basically, there's no good answer. So it's more opinion, as you mentioned. What I do is, what I do is, as you said, I test the patient. So sometimes it's okay to test the patient with an anti-VEGF. Maybe you don't have access to angiography. All of you will graduate, and some people will have access to angiography, and many of you won't. So sometimes it's okay to test with an anti-VEGF as long as the patient understands the risk. And I tell the patient this is considered experimental. And based on the results, I'll document whether the patient is responsive or unresponsive to anti-VEGF. And if they're responsive, I'll say, diagnosis likely MACTEL, however, responsive to anti-VEGF. And if they're responsive, then of course, we'll continue treatment as long as we think it's beneficial. But I don't know if it removes the etiology or changes anything about the etiology. But if there is a responsive component to their disease, then yes, I would treat with anti-VEGF.
Thank you.
You're welcome. Okay, so to the cases. So this is an Optos photo. I love to get Optos on every single patient. I think it's very helpful for not just documentation, but helpful for analysis, and using that in addition to examining the patient. I think it just makes my life much easier. Of course, we cannot charge for the Optos, the patient, but we still do it. We still do it anyways. Emmanuel, do you want to select?
Πέτρος Δόβας, θα μας το περιγράψεις.
Okay, so we can see a fundus photo, which looks to have something like a pre-retinal or vitreous hemorrhage, extended one. And can also see some dot blot retinal hemorrhages to the right. Mm-hmm. And to the left, there are some yellow spots that they could be like confluent soft drusens.
Mm-hmm. And what do you do next in terms of history for the getting the history for the patient, and then management of the patient? And
okay.
just to note, there's a little more hemorrhage here, a little more confluent hemorrhage in the retina over there.
Yeah, the resolution is not perfect. So my next step would be to take a history of a kind of disease like diabetes or any other kind of arterial or venous disease, and order again a phalangiography to see what's happening under the Brooks membrane. if there's a kind of vascularization.
Okay. So the patient here, does look to be diabetic. They did an angiogram and it shows some neovascularization, as you would expect. And what do you do next?
So that means that we have a proliferative diabetic retinopathy in this patient. And
how do you manage?
This is an indication for urgent for initiation of PRP, of peripheral photopexy.
Mm-hmm.
In order
all the PRP in one session? Do you do multiple?
I would start from the lower quadrants, because if the vitreous hemorrhage persists, this quadrant will be lost from my view in later sessions. So
Mm-hmm.
that is one thought.
Mm-hmm. Do you combine with anti-VEGF injection as well?
I'm not sure about that.
Okay.
We are just starting because Lucentis has been approved for PDR, so we will be starting combining PRP with anti-VEGF, but we haven't done that so far. So yeah.
So it has been approved, so we can combine them.
And right now, the use of Avastin, do you use Avastin as well?
We are not allowed to use Avastin in the public sector. We're not allowed. Only medications that are approved for the eye, Eylea and Lucentis.
Okay.
The Ministry of Health is not allowing us to use Avastin in the public sector, so no.
What do you do for a neovascular glaucoma?
We send them to the glaucoma specialist.
Okay. Okay. Wow.
Or we advise that they can go privately and do it, but we don't do it in the public hospital.
And so anybody who has a tractional retinal detachment.
Yeah. So what we do off the record is that when we do the normal injections, we can preserve some leftovers of the Lucentis and give it to the patient that needs them off-label. You know what I mean?
Yeah. Okay. Perfect. Another patient that came to see me a few months ago, and here it's very.
Let's Nikos Lafyoniatis describe this. Nikos, let's go.
Okay, we have also a fundus photography. We can see some dot hemorrhages and a big intraretinal hemorrhage and vitreous and hemorrhage in the vitreous.
So you guys have not had the experience of having to decide when to use anti-VEGF, so this is a good slide for you. When we combine the Lucentis and the PRP, you have to be very careful about crunch syndrome. Do you know what crunch syndrome is?
No.
So when you inject anti-VEGF, all of this NV, this scaffold, so the definition of NVE is not just the abnormal blood vessels growing into the vitreous, but it brings a scaffold with it. So it brings a home with it. If you do PRP, the NV goes away, but the scaffold does not go away, it stays. So imagine if instead of doing slowly PRP, you inject a full dose of anti-VEGF all at once, this complex could collapse. When the complex collapses, it increases traction on the residual retina. If it increases traction on the residual retina, you could end up with either just a tractional retinal detachment or a combined tractional retinal detachment plus rhegmatogenous retinal detachment, which is the worst kind of diabetic detachment to have when you have a combined rhegma and tractional. So you have to be very careful to decide which patients you inject with Lucentis for proliferative diabetic retinopathy. So if a patient, I'll give you a few scenarios. If a patient presents with vitreous hemorrhage and you cannot see the retina, then you should do a B scan to see how much traction there is on the macula. If there is too much traction on the macula, you do not want to be injecting anti-VEGF into that patient, because then the patient could detach. If the patient has a lot of this scaffolding and NV, you're basically looking for the traction. And if they have this traction, whether it's peripheral or whether it's close to the retina, you just have to be very careful that you don't want to take a patient with PDR and advance their diagnosis. Does that make sense? So, and of course, the patients are very young. So these can be very young. So the patients that are very young, their vitreous is very adherent to the retina. So doing a vitrectomy is not as easy as just going in and doing a vitrectomy. First of all, the patient is phakic. Second of all, to remove vitreous and tractional retinal detachment in a young patient is challenging. You will never remove as much vitreous as you want. You will always have peripheral vitreous remaining in a phakic patient, and more so in a young patient, and you have vitreoschisis as well. So you want to try to make your life and the patient's life as easy as possible. So for this patient, I would not only do PRP, I would do Lucentis, but I would do a half dose Lucentis. And it's better to do less is more. It's better to do smaller doses of the Lucentis, similar to if you had a lot of traction, I would do partial PRP. I would never, if this was bigger, this is manageable. This is considered on the smaller side. But if it was larger, or if it was threatening the fovea, I would not do all the PRP at once. I would dose the PRP into 2-week, 1 to 2 week segments, so that it is not inducing so much change at once.
And without, how many shots per session? 500 or less than 500?
About 400 to 500.
Yeah.
So the H&P for vitreous hemorrhage, we mentioned some that if they're diabetic, but there's the most important question to ask over the phone. So if somebody calls you, you have a referring doctor that says, I have a patient with vitreous hemorrhage. The second question to ask is, has the patient have flashes? If the patient has flashes in addition to vitreous hemorrhage, then you have to be worried about a tear that is causing the vitreous hemorrhage, of course. So if the patient has diabetes or diabetic retinopathy, it is unlikely that after PRP that they also get a tear. You could get it in both, but it's unlikely. So we ask about flashes. We ask about whether they've had trauma or blunt trauma. Diabetic, hypertensive. The reason why we ask about hypertensive is maybe they had a vein occlusion and the vein occlusion led to the proliferative diabetic retinopathy. We ask about family history, of course, of retinal detachment. We ask whether the patient has had prior laser. We ask about the status of the fellow eye. If the patient is diabetic and has 0 diabetic retinopathy in the fellow eye, then it is very unlikely that they have proliferative diabetic retinopathy in this eye. Most likely the vitreous hemorrhage is from a different reason. And then, of course, we ask about NVI. If the patient has NVI, or we look for it on examination. So in terms of differential for this scotoma of the vitreous hemorrhage, there's other less likely things, ocular ischemic syndrome, sickle cell, pars planitis. And then I think in Greece you have more thalassemia, right, than in North America. So I would add more thalassemia to this list as well. 3 layers of hemorrhage. If you get hemorrhage in 3 layers of the retina, meaning subretinal, intraretinal, and vitreous hemorrhage, then you would think of other etiologies like choroidal neovascularization, like a macular degeneration, or macroaneurysm. We write MAA for that. And of course, trauma, shaken baby, if it's appropriate. The third reason that you could have vitreous hemorrhage is, as I mentioned, traction. So posterior vitreous detachment, a retinal tear or detachment. And then the other reasons would be subarachnoid heme, Eales disease or Behçet's. So when I see the patient, we scleral depress for tears. We do a B scan if we can't see that the retina is attached. Of course, we ask them to leave their head, the head of the bed elevated. In addition to PRP, if there's no view for PRP, it's okay to do a vitrectomy. If the patient's monocular, it's okay to schedule it early, so within a month or so. If the patient's monocular, or if they're high risk without prior PRP. So what would be considered high risk? Well, let's say the fellow eye had PRP for proliferative diabetic retinopathy, then you know this eye is most likely to be advanced. So it's okay to take them to the operating room. If you diagnose a tear in the periphery on B scan, but you don't have any view to the tear on examination, that's also a reason to bring them to the operating room to remove the hemorrhage, because you do not want that tear to turn into a rhegmatogenous retinal detachment, because again, that is a very difficult detachment to fix when you have a big hemorrhage and the detachment. Okay, so what would cause this kind of scotoma? Emmanuel, do you want to choose someone?
Έλενα, θα ήθελες λίγο να μας πεις?
It seems like it's a fundus photo, and it seems like a subretinal hemorrhage. In this case, maybe we have to do an RTPA and pneumatically remove the hemorrhage from this from fovea.
So very, very excellent answer. So subretinal hemorrhage. But here, what layer is this part?
It could be also intraretinal hemorrhage.
Yeah, could be. Let me show you this picture.
We see in the OCT that there is a disorganization, or there is subretinal hemorrhage, and hemorrhage in all the layers of the retina.
So what layer is this? What would you say?
From nerve fiber or ganglion cells?
Yeah, it could be right in the middle of the nerve fiber layer. You see some nerve fiber layer here. Typically, you would expect a sub-ILM hemorrhage. That's a very common hemorrhage, to have a sub-ILM hemorrhage. And actually, a sub-ILM hemorrhage is what led Robert Wendell, who invented, Kelly and Wendell invented macular hole surgery, I think 1990 or something. So the reason why they knew that you can safely peel the ILM is because there was a patient who presented with sub-ILM hemorrhage, and the patient could see completely fine. So they knew that when you separate the ILM from the retina, that it is safe. And so that's what led to macular hole surgery and peeling the ILM of the macular hole. That's Dr. Robert Wendell. So yes, this is retina hemorrhage in multiple layers of the retina. So as you mentioned, so what you guys do is you inject TPA in the clinic, and you do pneumatic displacement in the clinic. Is that what you do? Or do you take them to the operating room? Sorry, who is the resident that
Elena.
I don't know if we do it because RTPA is not easily available. I don't know if we do it in the hospital.
Okay, so For us, as you said, TPA is very difficult to get in the clinic. So if you can take them to the hospital, you can order it there in the hospital, and you can inject them. And then, yes, we do a pneumatic displacement where we inject 100% gas, and we have them position about 45 degrees down to displace the hemorrhage. This patient we had in the clinic, so we did not have access to TPA. So we just injected the bubble. You can see here there was a very nice, in 2 days, there was a very nice improvement in subretinal heme. This is the gas bubble. On follow-up, you can see the ILM, or the interretinal heme here, persist, but the subretinal heme got displaced inferiorly. So very interesting follow-up. And then we shut down for COVID. So we have not seen the patient back since then. Okay, who wants to tell me what the
what do you inject, DEEPA, SF6 or C3F8?
I inject C3F8 in order to get a bigger bubble.
Right. Okay.
So there's a couple of things. Emmanuel is very well trained in pneumatics, because in Canada we do lots and lots and lots of pneumatics. Emmanuel's best friend in Canada, Paul Tesha, I think did 100 pneumatics over Christmas and New Year's. 1 year during our fellowship, Paul Tesha was my co-fellow. He's in England. I don't know what the culture is in Greece. In the United States, pneumatic is not popular at all. So strategies for bubbling. For this, you want to get the bubble as big as possible, because the eye is full of vitreous. And so it's hard to get all the way to cover this area and to move this area. So I would inject C3F8 because it expands 4 times its size. And if I felt that the bubble is not large enough, then I would double bubble. So I would inject them again a few days later. Because the patient already had a good bubble size, then we did not have to re-inject. Emmanuel, do you do something different?
No, pretty much the same.
Okay, so last couple of cases. I think we have 3 cases. Does someone want to tell me what the diagnosis is here?
Nikos Lafreniatis. Petro Dova.
I will say that maybe it's a branch retinal artery occlusion, because there's an inferior scotoma.
Okay, and what do you do next?
I'll do full.
Sorry, it should be superior scotoma, not inferior scotoma. My bad. What do you do next?
Order a full cardiologic follow-up with complete blood counts and triplex of carotid arteries, ultrasound. How old is the patient?
This patient was 62.
Okay. Do an OCT to see if there is macular edema. And consider ordering anti-VEGF therapy.
Okay, if there's macular edema.
Yeah.
Can you tell me what your cardiac workup consists of? Do you send them to the emergency room? Do you order as an outpatient? What is your procedure there?
If we see them at the outpatient, we order them to do it either the same day in the hospital or outside of the hospital. That would include checking for thrombophilia, lipid profile, ultrasound of heart, triplex of carotid, to see if there's an occlusion there, or if the patient is younger, maybe some more specific examinations like protein S or protein C, cardiolipins.
Do you do homocysteine?
Homocysteine, yes.
Good, very good.
Complement.
Yeah, you can check protein C as antithrombin 3, factor 5 Leiden.
Yes.
If they're younger, of course, the CBC in general, and you don't do MRI there, right?
From what I know, no, I haven't seen anyone to order MRI for this patient.
Okay, well, that's wonderful, wonderful. And in terms of imaging, you said OCT. Any other imaging you can do? Other than, of course, angiogram, but autofluorescence is a nice image to take as well. Do you see here?
Yes, there is an occlusion. The occlusion is pretty clear. I think this is called the Hollenhorst.
Yeah.
The Hollenhorst sign.
Yeah. Embolus.
Embolus, yeah.
And it shows very nicely on autofluorescence. So that's great. And you managed perfectly. The patient did not have fluid in the retina, so we don't do injections. But typically, a branch retinal vein occlusion, a branch retinal artery occlusion, if they have good vision, we don't do anything about it. If they have 20/50 or 20/40 vision or better, we typically don't do anything heroic. Okay, so this is a monocular patient. He's a chiropractor. He presented in, I think, January or February, and he presented with a central scotoma in the left eye, his only eye, and he basically has lost his center vision. Does anyone want to tell me if they can explain why? Or does anyone want to tell me what they see? They may not be able to explain why.
Well, although the resolution of the image is a bit poor, what I can see is the presence of dot and blotch hemorrhages in all quadrants. Could it be venous stasis syndrome or non-ischemic CRVO, diabetic? Actually, the only findings I can see by this image are the hemorrhages.
I completely agree with you. The patient presented with central scotoma within the last 24 hours. Can you explain why the patient has central scotoma, assuming anterior segment exam is normal?
Due to the presence of macular edema and do I see bone spicules? Are there bone spicules?
No. Well, you can have some RPE changes, but
okay.
I don't see anything here that could explain just on fundus examination. Mm-hmm. So this is his OCT. Do you see anything here that would explain his central scotoma?
Only the fact that the inner retina is a bit hyperreflective. So could this be a sign of inner retinal ischemia?
I'll show you his angiogram. So this is his angiogram. This is actually 45 seconds.
Mm-hmm.
Oh, I gave it away.
It is delayed.
Yeah, so basically, you're right. There's inner ischemia, but it's a delayed filling, right?
It is delayed filling, yes.
Yeah, it should fill a little bit earlier. The rest of the angiogram is completely normal, and actually, when we first got the angiogram, the timer was wrong. So when we got the angiogram, we saw the pictures and it looked like it was early, but we went and called the director of the photography to see if there's anything peculiar. And they said, yes, they had to restart the clock because they thought something was wrong with the filling. So we didn't have this information. We just had this OCT. That's basically the only thing that we could find in the macula with, as you astutely mentioned, you have hemorrhages in the periphery. So this would be a combination central retinal artery occlusion and vein occlusion. So what happened to this patient? We sent the patient to the emergency room for their cardiac workup, as we just described with the branch retinal artery occlusion. He did not have anything. The patient was 68, I think.
Any GCA symptoms? Sorry to interrupt.
That's exactly why we sent him. So he did not have GCA, giant cell arteritis symptoms, but we did send him for ESR, CRP, platelets, and we sent him for carotids, echo, and an MRI. And everything was normal because, of course, for a scotoma, you want to make sure there's nothing going on in his brain that could explain it as well. So everything was normal. So his diagnosis is the combined central retinal artery occlusion and central retinal vein occlusion. And as we followed him, he developed macular edema consistent with the central retinal vein occlusion part. Maybe about a few months after. It took a few months for the macular edema to develop. So just in terms of treatment, so let's say the patient presents within 3 hours of a central retinal artery occlusion. His vision is, basically count fingers, or 2400 according to our measurements, which is very poor. Do you guys do anything in terms of stenting or anything if the patient presents very quickly after their artery occlusion?
Massage the eye with a Goldman lens in order, if there is a chance, to remove the embolus.
Mm-hmm.
Maybe 20, 50 or 500 milligrams of acetazolamide to reduce the intraocular pressure.
You do paracentesis?
And paracentesis. Well,
Yeah.
not routinely, but.
Yeah, I do paracentesis just to collapse the eye, and just sometimes you need this sudden change in pressure to dislodge the clot. Of course, there's no good treatment for central retinal artery occlusion. There are places in Toronto that do interventional the interventional radiologist comes in and opens up the ophthalmic artery. I mean, there are, these are very highly risky procedures, but there are places that do that. But you have to present very quickly, obviously. Presenting in 24 hours is too late. So I just wanted to know in Greece whether there's any centers that do the more invasive procedures for a blinding central retinal artery occlusion.
I don't think we have, actually, no. Okay. But we do AC paracentesis, yes, we do.
Yes, for sure, great. Okay, so patient presents to you with a funny looking nerve. What do you do next?
Elena?
It seems like there is a prominence of the papilla. I would do the investigation for optic nerve edema.
Okay, so what does that include?
Infectious diseases, ischemic diseases, gigatory arteritis or other autoimmune diseases.
So what are you saying you order the labs in your clinic? I'm assuming it means you order labs is your next step.
I would firstly exclude the most severe ones, and then I will do the rest.
Okay, so what does that include?
Gigantoric arteritis, ischemia of the optic nerve.
So what if I told you the patient was 22 years old? So if it's an older patient which presents with, you know, fullness of the optic nerve, and they have diabetes and high blood pressure, then oftentimes you assume it's an ischemic optic neuropathy. If it's a younger patient, you know, you have to change what your differential would be. So the question here is, what would be your next step? What I mean is, what would be your next step in the clinic? What would you do next in the clinic? Is there certain imaging you would order?
Exclude the infectious ones. I will do the CRP and the
ESR.
ESR, yes.
So this is the most common. So as a retina specialist, of course, I only like to treat retina, but there's not very many neuro-ophthalmologists around, so sometimes retina people get referred optic nerve issues. So the diagnosis of this is actually the most common thing that I get referred for. And in terms of what I would do in my clinic as my next step now is I would order autofluorescence. So can you tell me what this autofluorescence shows?
It shows drusen papilla, I would say.
Yes, yes. So this is optic disc drusen. So you have drusen in the optic nerve. You can have buried drusen, or you can have more superficial drusen. And if you do an OCT, sometimes you see these ring type of, you know, these clear spaces with rings that have shadowing underneath. And so the next step, you know, of course, an Optos color is not the same as looking at the examination of the patient, but sometimes optic disc edema from, you know, something going on in your brain or infectious can look the same as optic nerve head drusen. And the reason for that is because the drusen can be buried and you don't know what's causing the fullness. So my first order, I don't know if you have, do you have autofluorescence in your clinic? Is it easy to get autofluorescence? Emmanuel disappeared. Does someone else know if there's autofluorescence in the clinic?
Yes, we have.
You do?
Yes,
okay.
We have.
We do it regularly.
Perfect. So if the autofluorescence is not costing the patient anymore, then I think it's a great next step.
You missed me. I just went for a second and you missed me. Yes, we do autofluorescence. We do have autofluorescence, yes.
Perfect. Yeah, so it's a great next step to do. Drusen doesn't always show up on autofluorescence, but it's nice when it does show up. And you can do OCT as well for that sign, and you can also do B scan, of course, to look for shadowing because of the calcium. So do you guys do any management of optic disc drusen? Any experimental treatment?
Alexander, are you online? Yes, you are. Any management for the optic disc drusen? What do you? I don't do anything about personally. I don't know if you do anything.
No direct management. In terms of, I look for the associations of the optic nerve drusen, but usually you have other stigmata of disease, you have retinal dystrophies and so forth. And also what I occasionally get is a baseline visual field. So we have some kind of documentation of what the visual function is. So we need, if in terms of if something occurs in the future, we have a baseline to compare with. And that's the only thing I get.
Yeah. So there's some, I was at a neuro lecture the other day, and there are some recommendations that if there are visual field changes, because of course optic disc drusen can cause visual field changes, that there are some people treating with alpha-GAN as a neuroprotectant. So I don't know if there's any evidence, like when I say evidence, I mean type 1 evidence, prospective randomized clinical trials. I don't know if there's anything like that, but I have heard of some people using alpha-GAN. Again, the neuroprotection of alpha-GAN is also controversial.
Right. This neuroprotection thing about alpha-GAN is, something that we hear a lot, but it's. To tell you the truth, I actually do it for non-ischemic optic neuropathies, like an acute AION. I use it for maybe 4 or 6 weeks. But in something like chronic, like I don't want to necessarily give them something that the most likely thing will give them is an allergy or some kind of toxic conjunctivitis for some kind of neuroprotection. But I think that getting a visual field is a useful thing because you always have something to compare. You actually realize that what we call an innocent disease, there's nothing. Usually, what we say that it's nothing. It's a pseudoedema, so it's nothing. You actually do see visual field defects. That's for sure. That's for sure.
Thank you. Yes. Okay. So, patient presents with, has had PRP in the past for proliferative diabetic retinopathy. There does not look to be any NVD at this time. There's some dot blot hemorrhages, but does not look to be any NVE either. When we look at the left eye, so what happened, oftentimes in the United States, people lose their insurance. And Detroit is very bad socioeconomic differences where you have rich people in the suburbs and very poor people in the downtown area. Majority African American downtown who do not have good access to medicine or to healthcare. So patients may get insurance and then they may lose their insurance. So obviously this patient had insurance, got their PRP laser, and then lost their insurance and then never got their other eye treated. Of course, it's not always insurance related. It could be that the patient just wasn't aware, didn't forget, or it was too rainy that day and didn't come in. I mean, there's a variety of reasons. I'm sure you get the variety of reasons over there as well. But there's different, I have a patient right now, I could even show you their photos that we're very concerned with. And my resident is trying to call him to get them to come in. And he's like, I just don't have a ride. I just don't have any way of coming to the clinic. And we told him, it's very important. And he's like, I just can't. I'll come in on Tuesday. It's a common thing around the world. So this unfortunate patient progressed. Their NVD and NVE progressed into traction. And you can see from the angiogram, so the right eye looks pretty good. Left eye, you can see that all of this retina is ischemic. You see that this is all dead retina. This retina is not going to work. And you have a very beautiful net of NVD and NVE around the macula, which leaks, of course. This is the traction on the fovea. So what would be your next step at this point? So, Emmanuel, do you want to?
Sure. Nikos Lafyoniadis. Κωνσταντίνα Μουρίκη.
if I can say something,
Sure.
this is the perfect case illustrating whoever is an opponent of panretinal photocoagulation for any other reason, you should show this picture. You know, you should show this patient and see what the one eye did and the other eye. What, you know, it's you know what we call, because it's nowadays we talk badly about PRP. You know, it causes visual field defects, peripheral vision changes. We have the new weapon. We have anti-VEGF. We have everything. But look at this case. I mean, this illustrates it's a disaster in one eye and the other eye what it looks like. So it's important to mention that. So.
And at last Tuesday's session of Retina Connect, we had Lee Jampel, Rick Ferris, Stuart Fine, and Mort Goldberg. So these are the people that designed the diabetic retinopathy study. These are the people that created the Early House diabetic retinopathy classification. And we had Barbara Blody also, who runs the reading center that interprets the DRCR-NET images. To have all of these people in one panel and discussing was like one of the most amazing experiences. And they talked about why PRP even came to be. So it is crazy to think that you should obliterate perfectly normal retina and sacrifice the retina to preserve the macula. The reason why they came to know that PRP is even a consideration is because the original treatment with xenon laser, xenon is the massive, very painful laser. Original treatment was for angiomas, but also for NVE. They would treat the NVE, and they noticed that if the patient had more NVE, meaning they treated with laser more places, that the patients got better and didn't have any recurrence. So they thought, maybe it's the quantity of laser that the patients are getting. And so maybe we should try to laser all of this beautifully normal retina and sacrifice it to preserve the posterior part of it. So it's very interesting that, you know, this is the treatment, but many studies have shown that even if you try to convince the patient to come in for monthly anti-VEGF, that they could be the most knowledgeable patient. Of course, anti-VEGF looks nicer and it reverses your diabetic retinopathy score, and it's much easier on the patient, it's much easier on us. However, Charlie Wyckoff, who is one of the PIs for the Panorama study looking at peripheral ischemia, he was telling us a story about how he had an ENT surgeon, a female ENT surgeon, mother of two, you know, very well put together, is on some leadership panel at the hospital. She came in with PDR, and he offered her monthly anti-VEGF versus PRP, and she chose monthly anti-VEGF. And sure enough, she comes back 2 years later with massive tractional retinal detachments that are entering her sight of vision and making it difficult for her to operate. So she wanted to follow up with the doctor to figure out what she could do to help her operate. So he, you know, he doesn't understand how someone so educated and so well put together could do this. And she just misunderstood, or she just didn't think it was important, and she didn't come in for her follow-up injections, and she is now in a situation like this. So you cannot predict which patients are going to come back or not. So the safest thing that I do is I combine anti-VEGF with the PRP. So you buy time by injecting your Lucentis. It gives you more weeks to get in the PRP, and you can do the PRP slower. There's not so much of a rush to get the PRP in, but you get the advantages of reversing your diabetic retinopathy severity score, and you get the long-term treatment of the PRP. I think that is the safest thing to do with the patient. I don't know if the other retina attendings do something different or the same.
I totally agree. And one thing that is actually not discussed a lot, but as surgeons we see it a lot, it's a totally different thing getting into an eye with a tractional detachment without previous PRP done. And another thing, getting into an eye with good PRP done. Even if you have a tractional detachment in the macula, of course, it's a totally different thing. If you get stuck hyaloid and a taut hyaloid up to the mid-periphery, it's almost a disaster. If you just have it, even a tabletop, just posterior pole, you have good PRP in the periphery, it's something that it's, at least in my hands, it's manageable. And I think it makes a big difference for the average surgeon. Of course, if you're a magician, you can do everything. But it's something that it's underestimated, surgically speaking. This eye actually doesn't look that bad in the mid-periphery in terms of, traction. But in general, if you treat an eye, an abandoned eye with very bad disease without previous PRP, the surgery is much more challenging. And it almost always it leads to, silicone oil and bad results.
Yes. Sorry, Emmanuel, what were you going to say?
No, you go ahead, Deepa.
No, exactly. It's these eyes have a path and a plan of their own, and it's very hard to interfere with that snowball of, the end of the eye. And sometimes you can operate, and the vitreous alone is the reason why the patients don't detach. And you can spend hours peeling and peeling and peeling without any hole, and then you get one hole and it's over. So I completely agree. The way I approach my tractional retinal detachments for a case like this, I would never inject anti-VEGF ahead of time, because of course the macula is already detached. You don't want it to turn rhegmatogenous. I would actually, before surgery, I would do the PRP exactly as you said. Maybe not complete PRP, but I want to get the anti-VEGF process started. Anti-VEGF meaning anti-VEGF from PRP. So I would start with some moderate PRP slowly in preparation for surgery, and then take them to the operating room and hopefully enter a more calm eye than a very hot eye full of anti-VEGF. I like to do 27 gauge cutters for the dissection within a 25 gauge platform. So we have the 27 gauge cutter separate from the 25 gauge. So it doesn't cost any too much more to add the 27 gauge. And I love the Alcon, the slanted. We have both Bausch & Lomb. I have Bausch & Lomb Elite, Stellaris Elite in, Elite in Canada, and I have Alcon in the US, and we're trying to get the EVA at another hospital. I'd like to be able to operate with all three. The Alcon, the tip is slanted, so it's really, you can touch the retina actually now with the, well, I don't want to encourage the trainees to touch the retina, but meaning you can get very, very close to the retina with your tip and have the port close to the tip, and the edge is beveled, and you can really get under all of these little spots and see and cleave the plane between the scaffolding and the retina. I don't like that this 27 gauge is slow, so I do the regular vitrectomy, core vitrectomy part with the 25 gauge. Okay, great. Well, it's the 2-hour mark, so I do have other cases, but I'm going to stop there. I have some mystery cases that maybe I'll email you, Emmanuel, and you can send to these very intelligent faculty, retina, and residents for their opinion. We have a case now of this patient that I'm trying to get in that we don't know what to do with, so I can send you some of those cases as well. Thank you very much for listening and for attending this late into a night on your Friday night. I guess nobody is out partying these days or having the chance and opportunity to go out for fancy dinners. So for retina people, maybe this is the next best thing.
Great. Thank you so much, Deepa.